Okay, well, good morning. Thanks everyone for being here. I understand how precious our time is, so it really means a lot for you to spend the next couple hours with us. And really, I'm going to give you, over the next 90 minutes, give you the kind of the 20-year journey on the discovery of nitric oxide and how we've been able to translate these basic science discoveries into product technology that we're developing for drug therapies and perhaps most importantly, consumer products that have been proven safe and effective for restoration of nitric oxide. So thanks for the kind introduction, and it kind of gave you a background of kind of where I started, and now I'll show you where I'm headed. But when I started my own independent research career in academia, we were really focused on trying to answer four questions. How does the human body naturally produce nitric oxide? What goes wrong in people that can't make it? How do they present clinically? If you develop nitric oxide deficiency, how does this present clinically? And then most importantly, which I'll share with you towards the end, is how do we fix or restore endogenous nitric oxide production? Because hopefully I'll convince you that this is one of the most important molecules produced in the body of humans. And as you mentioned, this 20 years in academia and drug discovery, of dozens of issued patents, have published over 100 peer-reviewed papers in the scientific literature, and I've given over 300 lectures around the world. These are my conflicts of interest. We've commercialized and productized a lot of the discoveries. I'm gonna tell you a little bit about our drug discovery program through Bryan Therapeutics, but this is just to inform you that obviously I have a conflict of interest. We've been able to very successful at commercializing some of the discoveries. But in academia and really in research and development, my job is to see what everyone else has seen, but to think what no one else has thought. And what I hope to share with you is kind of give you some of those original discoveries and original observations where we were able to see what everyone else had been thinking, but thought a little bit differently, and how this change in thought really changed the paradigm on how we deliver safe and effective nitric oxide. So obviously, I'm going to spend the majority of this time on nitric oxide, but as you're going to learn through this entire Real Truth About Health Summit, there are other important concepts in medicine and physiology that have to be addressed. So nitric oxide is foundational. It's extremely important, but I want to make it very clear. This is not a silver bullet. This is not an end-all, be-all, cure-all. You still have to address other root causes. And so broadly speaking, what I've learned in 25 years in academia is that people get sick for two reasons and two reasons only. Number one, their body's exposed to something that's toxic. And number two, the body's missing something that it needs. And whether it's a nutrient deficiency or exposure to a toxicant, the end result is disruption in nitric oxide production, decreased circulation, increased inflammation, oxidative stress, and immune dysfunction. And that bottom sentence explains every single chronic disease, whether it's diabetes, cardiovascular disease, Alzheimer's, autoimmune disease, liver disease, lung disease, neurological disease. It's decreased blood flow, increased inflammation, oxidative stress, and immune dysfunction. And I'm going to show you how to get to the root cause of all of those. So first, let me just start out, because I like to start out with broad concepts and kind of lead you on this kind of delving deeper into the underlying biochemistry and physiology. But the one thing that I like to start with is look at important clinical observations. And then if we can take important clinical observations and work backwards and figure out what's leading to that clinical presentation, then and only then can we develop safe and effective product technology. And so this is the work of Daniel Amen. Dr. Amen has one of the largest databases of SPECT scans in the world on his patients. And a SPECT scan tells us how well perfused an organ is. And in this case, it's the brain. So on the left, you can see a healthy brain, and this nicely contoured SPECT image tells us that all regions of the brain are getting sufficient blood supply, adequately perfused, and obviously this patient doesn't have any neurological deficits or neurological problems. If you look on the right in the SPECT scan of an Alzheimer's brain, you can see that's completely different than a healthy brain. And so these holes in the brain are areas in the brain in which there's decreased perfusion, and we call this focal ischemia. Select parts of the brain that aren't getting adequate blood supply. So what happens? Well, the brain atrophies. We don't get the good stuff in. We don't take out the waste products. You get misfolding of protein. You get insulin resistance, type 3 diabetes. And those are the underlying hallmarks of Alzheimer's disease. So, and then if you look in an angiogram, obviously this is an invasive type of imaging. And in this patient, you can see here in the angiogram here that there's a thrombus or an occlusion in the left circumflex. So this patient presented with a heart attack, shortness of breath, chest pain. Fortunately, he was taken to the cath lab and reperfused. They aspirated this thrombus in the left circumflex. And you can see here completely restored coronary flow. And if you do this in a timely manner, you can completely preserve the function of that organ. So in this patient here, even though he suffered a heart attack, complete occlusion of the left circumflex, when we restored blood flow to that organ, he came out with normal cardiac function. No necrosis, no myocardial infarction, normal cardiac contractility, and normal function. And then if you dig a little bit deeper and look at neurons, whether they're sensory or motor neurons, these are tissues and cells that have to have adequate blood supply. So these neurons are typically very well perfused because we have to deliver oxygen, nutrients, sodium, potassium to these neurons so they can initiate an action potential to conduct nerve transmission. But when you develop microvascular disease and these small blood vessels become chronically constricted, then these neurons atrophy. And this is the basis for peripheral neuropathy. So the whole point of taking these three examples, the brain, the heart, and nerve tissue, is that every single chronic disease is characterized by decreased blood flow to that affected organ. But if I showed you, if you can restore blood flow, you can correct many of these chronic conditions. So the next question is, how do we do this? And that's the role of nitric oxide. And so nitric oxide is a gas. It's naturally produced in the body. And once it's produced, it's gone in less than a second. But during that second it's around, it activates a number of cell signaling pathways that then start these second messenger systems that lead to a number of important biological and physiological effects. It's a free radical, meaning that it has an unpaired electron, but because of the polarity of this NO bond, nitric oxide is actually an electron donor. And any electron donating species is antioxidant, anti-inflammatory by nature. So that's a very important kind of a physical chemistry attribute of nitric oxide. And I like this quote by Val Fuster, who was famously quoted in 1998 that the discovery of nitric oxide and its function is one of the most important in the history of cardiovascular medicine. Now, fast forward 26 years, and that statement still holds true today. And I show you this seemingly very complicated slide here, but this is, again, one of these papers and publications and discoveries that completely changed the way we thought about nitric oxide. And this is from my good friend and colleague, Jonathan Stamler. But what he discovered, and he describes in this research study here, is that nitric oxide is required for oxygen uptake and oxygen delivery. So the cardiopulmonary cycle is a three-gas system. We breathe in oxygen, and we deliver that oxygen from the arteries to the veins and the capillaries, and then we pick up carbon dioxide, which is a metabolic waste product, and then we exhale that carbon dioxide in our exhaled breath. But this doesn't work unless we have that third gas, nitric oxide, bound to a cysteine residue on hemoglobin. So, and we saw this over the past 4 years, people with respiratory viral infections develop hypoxemia, right? So their blood oxygen saturation would go from a normal of 98 to 99 to, in some cases, high 70s, low 80s. And this is critical hypoxemia. So what do? We put them in the hospital. We give them 100% oxygen. That doesn't improve their oxygen saturation. So you put them on a mechanical vent. That still doesn't do it. And many patients died. But what we're finding is that if we could have just restored nitric oxide, which is what we did in our nitric oxide drug study, you can restore the functionality of nitric oxide. You can see blood oxygen saturation go from 78 to 96 within 8 minutes. And that's just breathing room air. So the problem is in these patients with COPD, emphysema, respiratory viruses is they're not lacking oxygen. They've lost the ability to take up oxygen and deliver oxygen because they've lost the ability to produce nitric oxide. So I'll come back to that at the end, but that's a very important concept when we look at tissue oxygenation and delivering oxygen to the tissue. But it's involved in basically every biological function. It's what controls gut motility in the periphery. I'm going to spend a little bit of time talking about the science around nitric oxide mobilizing stem cells, leading to regeneration, repairing, and replacing dysfunctional tissues. It's a neurotransmitter in the central nervous system, controls cell cycles. So in patients with cancer and metastatic disease, nitric oxide is critically important. It's a bronchodilator as well as a vasodilator. It's the molecule responsible for erections in both men and women. And it's part of our innate immune system. It's how our immune cells kill off invading pathogens from viruses to bacteria. So people who can't make nitric oxide, when you lose the ability to produce nitric oxide, you get multisystemic disease. You become immunocompromised. You get high blood pressure, erectile dysfunction, gastroparesis, advanced aging, sometimes metastatic disease. And the discovery of nitric oxide was deemed so important that in 1998, the Nobel Assembly awarded a Nobel Prize to Bob Furchtgott, Lou Ignarro, and Fred Murad for the discoveries for nitric oxide as a signaling molecule in the cardiovascular system. And these were kind of the leaders in the field, and I've been very fortunate to work and train under these Nobel laureates. As you mentioned, Fred recruited me to join the faculty of UT Medical School in Houston back in 2005. And Lou Ignarro remains a close friend and colleague and has written the foreword to several of my textbooks. But again, I'm going to start broadly because I think what we're all interested in this Real Truth About Health Summit is how do we live longer, but more importantly, how do we live better, free of disease? And this emerging field of longevity has really opened up therapeutic potential for addressing the root cause of aging. So there's three objective measures of aging. There's telomeres, there's mitochondrial dysfunction, so every age-related disease is associated with mitochondrial dysfunction, and then there's loss of stem cell function and repair. And I presented this concept over a decade ago that nitric oxide is the unified theory of aging because it's nitric oxide that controls and regulates telomerase activity, preventing telomere shortening. Nitric oxide is what induces mitochondrial biogenesis, improves ATP production, and nitric oxide is the signal that tells our own stem cells to mobilize and differentiate. So really quickly, I'm just going to take you through all these because I don't want you to take my word for it. I want to present to you the published peer-reviewed science. And so telomeres, as I mentioned, are the very ends of the chromosomes that with each cellular replication, these telomeres can become shorter. And so now it's known that shorter telomeres, shorter lifespan. If we can prevent telomere shortening, we can prevent early death, early demise. So this is a very rich area of science dating back to the late 90s. So where does nitric oxide come to play in this? Well, it was first discovered in the early 2000s that nitric oxide is what activates the enzyme that prevents telomere shortening. And not only is it affecting the function of the telomerase enzyme, it actually controls and regulates the genetic expression and translation of that enzyme. And as you'll see here in 2009, the very important discovery here that nitric oxide is the master signaling molecule in the regulation of telomerase activity and provides the opportunity for innovative therapeutic approaches based on using nitric oxide active compounds. And here's the kind of the co-expression of the eNOS enzyme with the estrogen receptor alpha. And so this co-localization that allows for the genetic expression of the telomerase enzyme. But the point I want to make, and I'm going to introduce this concept later on, this requires a functional NOS enzyme. This is the enzyme, nitric oxide synthase, that produces nitric oxide. So if this enzyme isn't coupled and functional, then not only do you not get the expression and the translation of the telomerase enzyme, even if it's expressed, it can't be active. So loss of nitric oxide leads to loss of telomerase activity and shorter telomeres. And then what about the mitochondria? The mitochondria are the energy-producing organelles of every cell in the body. Lower numbers of mitochondria, mitochondrial dysfunction are hallmarks of all age-related chronic disease. And it's nitric oxide that controls ATP production. That's the energy currency of the cell. It actually regulates oxidative stress and the production of reactive oxygen species. It induces apoptosis. And as I'll show you, it's the signal that tells the cell to produce more mitochondria. So it controls everything we know about the bioenergetics and the metabolism and energy production within the cell. So again, we start with important clinical observations. Everybody knows that moderate physical exercise is cardioprotective. Everybody knows that caloric restriction, intermittent fasting, certain dietary pathways are cardioprotective, cytoprotective. But these mechanisms and observations are dependent upon the cell's ability to produce nitric oxide. So when we start to exercise or we do caloric restriction, that activates the nitric oxide production in the cell, leads to cyclic GMP. this produces an activation of what's called PGC1 alpha, and then that induces mitochondrial biogenesis. And this is the pathway of sirtuins, NAD. Everything that promotes longevity is activating this PGC1 alpha, which is dependent upon the cell's ability to produce nitric oxide. If you develop endothelial dysfunction and have an uncoupled NOS, you can fast for 3 days, 40 days, whatever. You're never going to get induction of this pathway until we restore the production of nitric oxide. And it's extremely important in performance, and it's performance on the athletic field, it's performance in the boardroom in terms of cognition, and it's performance in the bedroom in maintaining normal erectile function. So mechanistically, we know that nitric oxide is what extends the oxygen gradient into tissue. This nitric oxide is a reversible inhibitor of cytochrome C oxidase, so it allows oxygen to diffuse further into tissue by occupying that binding spot that oxygen would normally bind to. And then we know that at complex 1 and complex 4, it actually inhibits superoxide production and electron leakage across the electron transport chain, thereby mitigating the oxidative stress, recoupling the electron transport chain, and leading to more efficient ATP production with less oxygen. So the point here is if your body can make sufficient nitric oxide, then this what sets the stage for performance. And again, it's not just athletic performance, it's performance by every definition we define in physiology and medicine. And then what about stem cells? So we're constantly wearing ourselves out. Aging is just the inability to repair and replace dysfunctional cells. And 20 years ago, it was once thought that the older we get, the less stem cells we have on board. So that's what leads to age-related disease. Now we know that there's an enormous reservoir of stem cells in our fat, in our adipose tissue. And most people accumulate more fat with age. So it's not a loss of stem cell availability. It's the loss of the signal to mobilize our own stem cells and to mobilize and differentiate and repair and replace dysfunctional cells. And again, I show you the original research in 2003. It was revealed for the first time that nitric oxide is the signal that tells our own stem cells to mobilize and differentiate. And then the work we published on shows that the bioavailability of nitric oxide in patients may predict stem cell therapy success or failure. So again, if you lose the ability to produce nitric oxide, you no longer mobilize stem cells. And that's why the older you get, the less you repair and recovery from an injury or from exercise. So broadly speaking, you need nitric oxide to control all aspects of aging, prevent telomere shortening, increase mitochondrial biogenesis, mitochondrial efficiency, and mobilize our own stem cells. But now let's look specifically at vascular biology. And this quote here by this English physician over 400 years ago really leads to what we know about vascular biology. So the older we get, and many of you do this through carotid intima media thickness and look at the intima hyperplasia here, but in many cases, you start to see plaque deposition under the lining of the blood vessel. This leads to an obstruction, or we call stenosis, of the blood vessels. But it's really not the overlying stenosis and obstruction in patients with coronary disease. It's the stability of the plaque. So when this underlying plaque in the intima becomes unstable, and we call this soft vulnerable plaque, and this plaque ruptures, that's what leads to acute myocardial infarction, sudden cardiac death, if it happens in the coronary arteries, or ischemic stroke, if it happens in the cerebral arteries. So today we understand this entire process of onset and progression of cardiovascular disease, plaque formation, plaque instability, and plaque rupture. And it all starts with the functional production of nitric oxide in the lining of the blood vessels. So as long as your endothelial cells, and these are the single layer of cells that line all blood vessels throughout the body, as long as they can produce sufficient nitric oxide, then you don't get the inflammation, oxidative stress, and immune dysfunction that leads to the onset and progression of cardiovascular disease. And in fact, the functional loss of nitric oxide precedes these structural changes by many years. And many times it's decades. So if you already have an increase in the carotid intima media thickness and overt disease, that tells us that you've been nitric oxide deficient for many, many years. But there's good news. If we can maintain normal nitric oxide production, then we can prevent this. But perhaps more importantly and therapeutically, if you have the advanced progression of disease, we're seeing now plaque regression. So we can actually reverse cardiovascular disease, stabilize unstable plaque, and lead to regression of this disease. And we can do this by focusing on a single molecule nitric oxide. So I'm trained as a biochemist and physiologist, so we don't just take important clinical observations, but we have to understand mechanism. And it's the inflammation, oxidative stress, and immune dysfunction that causes arteries to age and what leads to cardiovascular disease, which remains the #1 killer of men and women worldwide. And I'm going to take you through this, the original data showing that nitric oxide, increasing nitric oxide addresses all these issues around arterial aging. Let's start with oxidative stress. There are three cellular sources, three primary sources of oxidative stress, and this is superoxide and hydroxyl radical, these toxic, damaging oxygen radicals. And so here are the data showing that nitric oxide suppresses NADPH oxidase by post-translationally modifying this protein. Nitric oxide recouples the electron transport chain and inhibits superoxide production. And then in our paper in 2009, the enzyme that actually makes nitric oxide, if it's not coupled and functional, actually produces superoxide. So we know how to recouple NOS enzyme, prevent superoxide production, normalize nitric oxide production, which then, by the way, shuts down NADPH oxidase, shuts down the electron leakage and superoxide production from the electron transport chain. So focusing on restoring the production of nitric oxide addresses the root cause of oxidative stress. It's self-fixing. And the reaction, we know the kinetics of nitric oxide reacting. So nitric oxide not only suppresses and inhibits superoxide production, but even if there's always a little bit of superoxide being produced. And the only way to stop a radical reaction is through another radical. So nitric oxide binds to superoxide through this radical reaction, neutralizes this, and forms a cage-like molecule we call peroxynitrite. And then this is a cage-like molecule that simply rearranges to stabilize the electrons and forms inorganic nitrate. So you can see NO3 minus is the same as OONO minus. We also have enzymatic systems, thioredoxin, glutathione peroxidase, that detoxifies enzymatically this peroxynitrite into inorganic nitrite, which is a cardioprotective, cytoprotective molecule. So the whole point I want to make here is mechanistically, we know everything we know about nitric oxide and can understand the reaction kinetics and how it's working in an antioxidant and anti-inflammatory manner. So now I want to dig down into really the research we've done over the past 20 years, because before we can start to understand the mechanism of disease, we have to understand how does the human body produce nitric oxide? And I'm going to go a little bit into detail here because I think it's very important that each of you understand what pathways lead to nitric oxide production and then what you may be doing that's inhibiting these pathways. So the first pathway to be discovered was through an enzyme called nitric oxide synthase. You've heard me talk about this already. But this enzyme converts L-arginine, which is an amino acid, into nitric oxide. And this is based on the function of the enzyme. And then we also can improve nitric oxide from the diet based on the foods we eat, our dietary patterns, and as I'll show you, the presence of an oral bacteria and an oral microbiome. And then this pathway can create a source of nitric oxide. So one can compensate for the other. So if you eat a poor diet, but you have good endothelial function, then you really don't get into problems. And if you have endothelial dysfunction, but you can eat a good, healthy diet, then you really don't see many problems. But when you develop endothelial dysfunction, combine that with a Western diet, the standard American diet, it leads to complete nitric oxide deficiency, and we start to see onset of symptoms and the rapid progression of disease. So let me show you how this works in a normal, healthy individual. So this would be the cross-section of a blood vessel, and this red or pink here would be the lumen of the blood vessel. And the lining of these blood vessels are endothelial cells. This is the inside of the body, or the endothelium. And then surrounding every blood vessel is a layer of smooth muscle. And when smooth muscle contracts, it constricts the blood vessel. When smooth muscle relaxes, it dilates the blood vessel. So when we start to exercise, that's why it produces nitric oxide, and that's why exercise is medicine. It turns on this enzyme. As long as this enzyme is functional, converts arginine to nitric oxide, And nitric oxide is a gas. So part of it diffuses into the lumen, part of it diffuses into the smooth muscle. And there, in less than a second, it binds to an enzyme called guanyl cyclase. And then this enzyme converts GTP into cyclic GMP. And cyclic GMP is a second messenger that activates calcium release, leads to smooth muscle relaxation and vasodilation. And that's why nitric oxide is a vasodilator, because it activates the second messenger, cyclic GMP, smooth muscle relaxation, and vasodilation. But interestingly, this is where drugs like PD5 inhibitors, these are phosphodiesterase isoform 5 inhibitors. So in a normal active cell, you see an increase in cyclic GMP, activates calcium mobilization, and then this phosphodiesterase enzyme breaks down cyclic GMP. But if you can prevent the breakdown of cyclic GMP by using drugs like Viagra, you can potentiate the vasodilatory effects. And that's why these drugs are effective at improving erectile function in men, is because they dilate the blood vessels and they potentiate the vasodilatory effects of nitric oxide. And that's also the reason you're warned against a 4-hour erection, because you turn the signal off by the phosphodiesterase enzyme. If you inhibit that enzyme, then nitric oxide turns this switch on, and these PD5 inhibitors keep it on. So you have to worry about an unsafe drop in blood pressure, 4-hour erections, priapism, and necrosis of that organ. So this is a very serious condition. But interestingly, these drugs have been on the market for more than 25 years now, and clinically, 50% of the men that are prescribed drugs like Viagra, Cialis for erectile dysfunction or urinary symptoms of BPH don't respond. So they don't get better. And why is that? And it's because in these responders, they're not making enough nitric oxide here to activate the second messenger system. So without nitric oxide, there's no cyclic GMP. Without cyclic GMP, PD5 inhibitors can't work or potentiate the vasodilatory effects. So erectile dysfunction is a symptom of nitric oxide deficiency and the first sign of endothelial dysfunction. If we can restore nitric oxide production, we can overcome erectile dysfunction, and we can actually take non-responders to PD5 inhibition therapy and make them responders. And then more importantly, you can lower the dose of these drugs, making them safer and yet more effective. So what happens with this enzyme with age? And it's the dysfunctional enzyme that occurs the older we get. And there are a number of contributing factors to this. But these are 4 independent studies that look at the age-related loss of nitric oxide production through this enzyme. So we lose about 10 to 12% per decade. By the time we're 40 years old, we only have about 50% of the nitric oxide we had when we were younger. And this is the age that people start to feel the effects of aging. 50% of the men over the age of 40 self-report erectile dysfunction. 50%. And most men aren't going to self-report erectile dysfunction. So I think the numbers are much higher. But today we know that we can prevent this age-related decline, or we can accelerate it if you live the Western lifestyle. Today we see 20, 25-year-old kids that have the vascular age of a 60 or 70-year-old because of their diet, because of their lifestyle. And then we see 60, 70-year-old patients that have the biological age, of a 30 or 40-year-old. I turned 50 last November, but I have the biological age of a 32-year-old. So we now know how to shift this curve to the left and to the right and hopefully prevent the age-related decline in nitric oxide production. And here are the data that show you. So in this particular study, we take well-trained athletes, we put them on an exercise treadmill, we increase their workload, we start an IV and just pull peripheral blood. And the amount of nitrite that shows up in the plasma, which is an acute phase marker for nitric oxide production, predicts exercise capacity. And this study was published by my good friends and colleagues in Germany at Heinrich Heine University, showing that exercise capacity is predicted by the ability to produce nitric oxide. Now, if you do that same experiment in 50 to 60-year-old patients with known risk factors for cardiovascular disease, they failed to increase nitric oxide production in response to exercise. And so what happens, they fail on exercise stress test. If you can't produce nitric oxide to dilate the coronary arteries upon increasing workload, then you can't increase the perfusion or oxygenation of the myocardium, and then you start to see changes in electrical activity, and this is now diagnostic for ischemic heart disease and endothelial dysfunction. So let me just get into the biochemistry of this enzyme, nitric oxide synthase. To convert arginine to nitric oxide, this is a 5-electron multi-step oxidation reaction. And it's one of the few, if not only, enzymes that requires 8 different cofactors and substrates. So number one, this enzyme must be functional. It must be coupled. Number two, we must have a sufficient pool of reduced tetrahydrobiopterin, glutathione, sufficient oxygen, magnesium. 75% of Americans are deficient in magnesium. NADPH, which people with G6PD deficiency have a deficiency of NADPH, FAD, flavin-dependent cofactors, and then heme iron. A lot of people are anemic. So all of this has to happen at the right time in the right space for nitric oxide to be produced. And the nitric oxide synthase enzyme is two twins. We call a homodimer. And these two twins that come together allow for this sufficient flow of electrons to convert arginine into nitric oxide. And then we get citrulline as a byproduct. But if we have oxidative stress and BH4 becomes oxidized, this enzyme becomes uncoupled, and now we reduce molecular oxygen to superoxide instead of nitric oxide. So it's the oxidation of BH4 that leads to NOS uncoupling and is the rate-limiting step in nitric oxide production. So we have to be able to preserve the electrical potential of BH4 to BH2 ratios. And most people don't understand this. Obviously, you have to be trained in physical chemistry and biochemistry to understand this. And for every biomolecule, there's an electrical potential. So electrons are negatively charged compounds or molecules or subparticles. And so there's an electrical potential for every biomolecule that's needed to extract an electron from that. And every molecule has a different redox potential. If you don't understand this, then you cannot prevent NOS uncoupling and prevent oxidative stress. So the reason I tell you this is, nitric oxide was once considered a miracle molecule. And miracle implies that we don't have an explanation, that it just happens. We don't have a scientific explanation. Well, that was 30 years ago. Today, there's nothing miracle about nitric oxide because we understand mechanistically how it's produced, where it goes, what it becomes, how it signals, and we know how to control it. So it was once thought, well, if you want to improve nitric oxide production, let's give L-arginine. And as many of you are aware, there are dozens, if not hundreds, of L-arginine products on the market targeted towards nitric oxide. But here's what happens if you don't understand the underlying enzymopathy in the patients with endothelial dysfunction. In this study in 2006, they took patients who had just suffered a heart attack and had compromised heart function, so an ejection fraction of, let's say, certainly less than optimal, less than 50%. Then they gave them arginine to try to improve vascular stiffness, improve contractility. They gave the patients the arginine. It caused more death than the placebo. So arginine, when added to standard post-infarct therapy, does not improve vascular stiffness measurements or ejection fraction and is associated with higher post-infarct mortality. Arginine should not be recommended following acute MI. Okay, very important study. They did the same thing with peripheral artery disease in patients and found that if you give arginine to patients with peripheral artery disease, they actually get worse. Intermittent claudication gets worse. So the conclusions of this study was arginine is not useful in patients with intermittent claudication and peripheral artery disease. And why is that? It's because in these patients, the NOS enzyme is uncoupled. They're not deficient in L-arginine. They've lost the ability to utilize that amino acid to make nitric oxide. And when you give arginine to an uncoupled NOS, you create superoxide and you exacerbate the underlying condition. So arginine should not be used in patients with endothelial dysfunction. So now let me take you back almost 20 years ago. I was a professor of molecular medicine at the Institute of Molecular Medicine at the UT Medical School in Houston, in Texas. We asked some very simple questions and try to answer this through designing rational experiments. So our whole thought process was, can we prevent injury from heart attack if we increase nitric oxide production in the heart? Because many of you know, if you're physicians or consumers or patients, you probably know a family member who had sudden cardiac death. Their first sign and symptom of heart disease was death. And then we know people who have had a heart attack, a widowmaker, high up in the LAD. They get to the hospital, they reperfuse, and not only do they survive, but they thrive, and their heart is actually protected. They have normal ejection fraction post-MI. So what is it about a heart attack in one patient that leads to sudden cardiac death? That same heart attack in the same spot of the coronary arteries leads to mild symptoms, but obviously taking action, going and getting reperfused, and there's no injury to the heart. Can we recapitulate this in animal models? And can we trace this phenotype biochemically? So this is a study from 2006, and my colleagues, David Leffer, they created a transgenic mouse where they overexpressed the nitric oxide synthase only in the cardiac myocytes. So we want to increase nitric oxide production only in the heart. And then if you occlude the LAD, so in these studies, we do open heart surgery, we tie a ligature, a suture around the LAD, the coronary artery, for 1 hour. So we cause a heart attack for 1 hour, then we cut the ligature, the suture, and then reperfuse that heart for 24 hours. And then we can do echo on these mice looking at cardiac function, contractility. Then we harvest the heart, do histology, and look at the amount of infarct or injury in the heart. In this paper published in 2006, the mice that have sufficient nitric oxide or overexpression of nitric oxide in the heart don't see any injury from a heart attack. Very important clinical observation. So we started taking the blood of these mice and trying to understand what is it about these mice that confer that cardioprotection. And then we harvested the liver and found that the liver biochemistry looked like that of the heart. And just to show we had a clean transfection only in the heart, not the liver, you can see the Western blot here. There's no overexpression of the enzyme in the liver. And understand that nitric oxide produced in the heart is gone in less than a second. So it will not survive transit from the heart to the liver. But yet something is modifying the liver biochemistry. And so the next question was, what does this mean, if anything? So we cut off the blood supply to the liver for 1 hour. We reperfuse that liver for 5 hours. And then we look at liver enzymes. And these are transaminase enzymes that are reflective of liver injury. So higher enzyme levels, higher liver injury. Lower enzyme, less injury to the liver. So the nitric oxide that was produced in the heart led to protection of ischemia perfusion injury in the liver. And we published this paper in the Proceedings of the National Academy of Science in 2008, showing for the very first time that nitric oxide was a hormone. What's a hormone? It's a molecule produced in an endocrine gland that has systemic effects, like testosterone produced in the testes of men or estrogen produced in the ovaries of women. It's secreted from those organs, but it has systemic effects. Nitric oxide is no different. It's secreted in the organ, the endocrine glands, the endocrine cells, or the endothelial cells. It has systemic effects. And this was my eureka moment in science and my epiphany, because this told me all we have to do is produce nitric oxide in a single biological compartment. Obviously, we don't want to induce genetic manipulation or gene insertions into humans. What if we could generate nitric oxide gas in the oral cavity? It's absorbed and it goes systemic. And that's been the basis for everything we've done going forward. So then understanding that all we had to do, and in these cardiac-specific nitric oxide mice, we saw an increased levels of plasma levels of nitrite and nitrate. So then we actually designed this experiment in mice because it's very easy to control the diet in mice. It's very difficult, if not impossible, to control the diet in humans. So we put our mice on a Western diet, what we call the standard American diet, or the SAD diet. And then we basically could calculate how much we took away, and then we gave this back in the drinking water. So we could use diet as a way to modulate steady state levels of plasma and cardiac levels of nitrite and nitrate. And then again, we subject these mice to heart attack, 1 hour, no flow ischemia, 24-hour reperfusion. You can see the mice that were on the standard American diet, about 40% greater injury to the heart. And about 50% of these mice didn't survive out to 24 hours. So the mice on the standard American diet, we give them a heart attack, 50% died. The 50% that survived had about 40% greater infarct in the heart. So compromised contractility. And if we let these mice live, they'll eventually develop heart failure and die weeks or months later. But if we give this back in the drinking water and replete what we took out from the diet, 100% survive out to 24 hours and about 30% less infarct in the heart than the control animals. So improvement in mortality and improvement in protecting the contractility and the function of the heart. Now we thought, let's push the envelope. Let's take mice that can't make nitric oxide because we deleted the gene that makes nitric oxide, and we put them on a Western diet. And this is the typical American, right? The typical American that has endothelial dysfunction that eats a Western diet. And you can see here, we can actually completely modulate these steady state levels of nitrite nitrate simply by giving an eNOS deficient mice a standard diet or putting them on an American diet and then giving this back in the drinking water. And here's a cross-section of the heart. The eNOS deficient mice, you can see here, the white tissue in this cross-section of the heart is dead tissue. This is infarct, this is necrosis, there's no contractility function of this heart. If we give it back in the drinking water, you can see extreme protection, about 60% less infarct, simply by giving a supplemental dose of nitric oxide, or in this case, nitrite or nitrate. So that told us that we can use diet as a first-line intervention for patients that are at risk for heart attack and stroke, improve vasodilation, stabilize the plaque, and if they happen to have a heart attack, we can improve outcome and maintain the contractility and the function of the heart. Well, what about diabetes? You know, diabetes is a worldwide epidemic now. It's not just a westernized disease. We've known for many, many years that once you get diabetes,
Dr. Bryan, it seems like your audio was cut out.
so I'll continue and hopefully you can hear me.
Now I can.
Okay, so people typically don't die from diabetes. They'll die from the cardiovascular complications of diabetes, heart attack, stroke. And so when we knock out the gene that makes nitric oxide, the first phenotype is insulin-resistant type 2 diabetes. So these eNOS deficient mice develop diabetes, completely recapitulating human disease. So this suggested to me that if you become deficient or compromised in the ability to make nitric oxide, that leads to insulin resistance. If you don't correct it, that leads to diabetes. Once you get diabetes, it further suppresses nitric oxide production. So there's this feed-forward mechanism that you have to restore the production of nitric oxide in order to intervene and intercede into the progression of diabetes. And this is a complex slide, but I show you this because this is where we tried to interrogate the insulin signaling to try to figure out where does nitric oxide play a role in glucose uptake in managing hyperglycemia. And so for some of you, this may be very complicated, but just bear with me here. So when insulin is secreted from the beta cells of the pancreas, it binds to the insulin receptors. And through this transmembrane receptors, it activates some intracellular signaling. PI3 kinase, AMP kinase, which by the way is the target of metformin, the primary anti-diabetic drug. But this is where the literature led us astray because we knew what happened here, but the terminal step was glucose uptake through GLUT4 translocation. But we knew that AMP kinase and PI3 AKT kinase converged on the eNOS enzyme. And this leads to a phosphorylation of serine residues, turns the enzyme on, and produces nitric oxide. But we knew in diabetics that this enzyme didn't work. So you can activate it, stimulate it, but if it isn't coupled, it can't produce nitric oxide. So then what happens to glucose uptake? And we engineered some cells where we tagged green fluorescent protein to the GLUT4 transporter. So we can actually visualize in real time the GLUT4, or the green fluorescent protein, which is tagged to the GLUT4, go to the membrane when we activate it. So we can activate GLUT4 translocation and improve glucose uptake simply by giving nitric oxide or nitric oxide donor drugs. And we published this 10 years ago. Just like in hemoglobin, there's two cysteine residues that are conserved throughout evolution that when post-translationally modified, that's necessary and sufficient for GLUT4 translocation, enhancing glucose uptake. But if the cell can't make nitric oxide, GLUT4 never gets the signal. Just like our stem cells never get the signal because there's no nitric oxide, GLUT4 doesn't get the signal to go to the membrane and bring in glucose. So what happens? We get hyperglycemia. That tells our pancreas, hey, I need more insulin. Then we get hyperinsulinemia, hyperglycemia. That starts this entire inflammatory cascade that leads to diabetic neuropathy, diabetic macular degeneration, retinopathy. Everything we know about diabetes and metabolic disease can be explained by a loss of nitric oxide production. We've covered oxidative stress. What about inflammation? That's obviously the silent killer. We've known this for many decades. And inflammation is defined by when blood vessels become like Velcro, right? We get an upregulation of adhesion molecules, the monocytes, T cells, neutrophils stick, platelet becomes aggregated, activated, clot formation, plaque instability, plaque rupture. But it's known that if we can downregulate the adhesion molecules, prevent the adherence and the migration of these immune cells, you can prevent the onset and progression of vascular disease. And this has been the problem of the spike protein that we've witnessed over the past 4 years, whether it's active COVID disease or genetic manipulation by the mRNA that now induces spike protein production by your human cells. It's the spike protein that's toxic. It binds to ACE2 receptors, allows for the aggregation of monocytes, neutrophils, platelets. These platelets aggregate, your body breaks them down, you see an increase in D-dimer levels. So everything we know about spike protein, coronavirus, long COVID, the vascular inflammation that persists long after the active infection, again, can be explained by the dysfunctional endothelium and the inability to produce nitric oxide. And in 2009, we were able to visualize this in real time. So you can see here, maybe the video will play. I'm not sure. I'm going to turn off my video just for a second. So maybe we'll get better streaming here. But what this would show if the video would play was that you've got microvascular dysfunction. There's a number of monocytes and neutrophils that are stuck to the lining of the blood vessel, and a number of cells have migrated through. And so we can induce this through an atherogenic diet. And so if we give nitric oxide at the same time we're inducing this vascular inflammation, it's not playing, maybe it's a streaming issue. But you can see here visually, even though the video may not be playing, the still photo shows that the blood vessel is more dilated. But what the video would show is that these monocytes and neutrophils don't stick. So we've downregulated the ACE2 receptor, VCAM, ECAM, all these adhesion molecules. And so we don't get the adhesion and we don't get the migration of the immune cells into the media, and we prevent hyperplasia, we prevent the onset and progression of cardiovascular disease. So the whole point of showing you this is that we have to restore the production of nitric oxide or give nitric oxide active compounds to prevent the vascular inflammation. And then let me change course here, because this was at a time when we were very productive in the lab. We were publishing 10 or 12 original papers a year. I was contacted by a fellow that was a cardiologist, and he was trained in traditional Chinese medicine. And he came to me and asked, Nathan, do the traditional medicines that we've been using for thousands of years in Eastern medicine, is there a nitric oxide component to those medicines that have been known to safely and effectively address a number of chronic illnesses? So you know what? That's a pretty interesting question. So Yaping came to the lab, and his first assignment was I sent him to a local acupuncture shop, and I said, bring me back the herbs you as a physician would use to treat a patient with high blood pressure, post-infarct patients, patients with heart failure, coronary artery disease. And so he brought back, 8 or 10, maybe a dozen of these herbs. And so we did it. He taught me how to do this like they do it in the pharmacies in China. So we ground these up with a mortar and pestle. We did some simple extractions. And then we put them in a nitric oxide analyzer where we could detect nitric oxide gas coming off of these herbal extracts. And you can see here the first couple of things we put in there really didn't do anything. So it's really anticlimactic. And then we start to get a nitric oxide peak here and the sustained nitric oxide release. We wash it out. We take another herb. We put it in our reactor, and we take this burst of nitric oxide, then it comes back down, and it slowly releases nitric oxide. So if you're a medicinal chemist and you're developing nitric oxide donors, then this is exactly the pharmacokinetics you're looking for. Predictable, sustained nitric oxide release. So then I thought, well, let's do something crazy. Let's take this extract and combine it with this extract and see what happens. And when we combine these two, we could quantify the synergy that's been described for thousands of years by the ability of these two extracts to synergize and produce far more nitric oxide than it would have been with an additive effect. So these two herbs, unbeknownst to me at the time, are always used in combination because they seem to work better clinically. But yet nobody understood it. But this has held this test of time for thousands of years. So then we wash it out, repeated it, and we get the same exact nitric oxide release. So now we had the ability to dial in any level of nitric oxide depending upon how we mix these extracts. And then we were able to do countercurrent chromatography and extraction techniques where we identified the active components of this. But we published that in 2009, and this made Yaoping very famous in China. I went to China. I gave 8 lectures in 6 days in 7 different cities. But this was a revolution for them because we had explained mechanistically what they had seen clinically for thousands of years. So it brings scientific evidence to the traditional medicines that they've been using for thousands of years. But we thought, okay, we now understand mechanistically how these medicines are working. Can we utilize nature? Can we utilize diet and make this process better? And in order to understand this, we have to understand the atmospheric nitrogen cycle. So the air we breathe is 78% nitrogen. This nitrogen, this triple bond of the N2 is a very strong bond. So you need high energy to break this bond. And it's done primarily through lightning fixation. So we're finding now in areas of the US where there's a number of lightning storms, the soil is more enriched in nitrogen in the form of nitrate than in areas where there's less lightning storms. So any vegetables that we eat that's grown in the soil, they assimilate these nitrogen oxides, or any animals that we eat that eat the grass or the vegetables, then we're getting a source of these nitrogen oxides. So this is called nitrification or nitrogen fixing. The human body is actually denitrifying. So let me take you through this. I want to spend a little bit of time on it because I think it's very important you understand this. The mechanism of action of a plant-based diet, a Mediterranean diet, a Japanese diet, can be explained by nitric oxide. So these vegetables, green leafy vegetables, are specifically enriched in nitrate. So when we consume a little bit of spinach salad here, or kale or arugula, then 90 minutes after we consume that meal, the nitrate is extracted and concentrated in our salivary glands. So now after this meal, for the next 6, 8, 10 hours, we secrete nitrate in our saliva. There are bacteria that live on the crypts of the tongue, the dorsal part of the tongue, that perform this 2-electron reduction of nitrate to nitrite. And humans do not have this enzyme. So we're 100% dependent upon the oral bacteria to do this. And now, for the next 6, 8, 10 hours, our saliva is enriched in nitrite. When we swallow our own saliva, that hits the acid environment of the stomach, the pKa of nitrite is 3.4, which means at pH 3.4, 50% of nitrite becomes protonated and produces nitric oxide gas. What does that mean? If we produce nitric oxide gas in the lumen of the stomach, it's like our cardiac-specific transgenic mice. We're producing nitric oxide gas in a single biological compartment, and it leads to cytoprotection systemically. So here's the problem. There's at least 3 steps in this pathway that you have to achieve. Number one, there's a certain amount, a threshold of nitrate that we must get from our diet. We must get at least 300 to 400 milligrams per meal. And we've taken the standard American diet. We're only getting about 150 milligrams, and that's over 2 to 3 meals. So just like most Americans are deficient in magnesium and iodine and selenium and chromium from the foods we eat, we're a nitrate deficient population. We've modeled different dietary patterns. You can see here in this model here, this dotted line is the threshold of nitrate that you need to manage your blood pressure. The dietary approaches to stop hypertension and the Japanese diet are the only dietary patterns that exceed this. All of the dietary patterns fall well below this threshold. The next question was, okay, how much, if we wanted to change guidelines and make recommendations on how much broccoli, celery, or spinach would I need to eat to get this 300 to 400 milligrams of nitrate, then now we can make dietary recommendations to manage blood pressure. Makes sense. So we went, and this is in collaboration with Texas A&M. We went to Chicago, Dallas, Los Angeles, New York, and Raleigh, and we just bought vegetables off the shelf, broccoli, cabbage, celery, lettuce, spinach, brought it back to the lab, analyzed it. This is a figure from the paper we published in 2015. A lot of numbers. Let me simplify this for you. Let's take celery, the middle here. If you lived in Dallas or Los Angeles, you could go to the grocery store, buy 6 stalks of celery, eat those celery, get enough nitrate to manage your blood pressure. If you lived in New York, you have to eat about 30, 40, 50 stalks of celery. So again, this goes back to the regional differences in soil conditions, farming practices, and the variability, not just regionally, but across vegetable categories. I mean, you see here, cabbage has far less than, celery. And these are conventionally grown vegetables, vegetables that are grown in nitrogen-enriched soil. We compared this to organically grown vegetables. Organic has on average about 10 times less nitrate, 5 to 10 times less than conventionally grown. And people really don't know what organic means, right? We're conditioned to say, organic. What is organic? Well, to get an organic label in the US, no herbicides, no pesticides, which is very good, by the way, but there's restrictions on adding nitrogen-based fertilizers to the soil. Without nitrogen, without standardized nitrogen in the soil, you can't assimilate nitrate. Without assimilation of nitrate, you can't assimilate other nutrients like vitamin A, vitamin E, selenium, chromium. So organically grown vegetables are typically depleted in most of the vital nutrients, including nitrate. And then here's the other problem. Nitrate is inert in humans. We must have the bacteria in the oral cavity to metabolize this, or else we eat the nitrate in the vegetables, and if it's don't have the right bacteria, we urinate it out, we excrete it in our feces, or we sweat it out. The nitrate goes through the human body completely unchanged. We don't get a nitric oxide benefit from it. 2 out of 3 Americans wake up every morning and use mouthwash. 2 out of 3 Americans have an unsafe elevation in blood pressure. That's not coincidental. I'm going to take you through the data. There are 200 million prescriptions written for antacids every year. And now you can buy these antacids over the counter. There's Prilosec, Prevacid, Nexium. You can go and get these, and I'm going to show you the consequences of that. And then there's 200 million prescriptions written for antibiotics every year. So to me, it's no wonder why Americans are the sickest people on the planet, because number one, the food we eat is completely nutrient depleted. And then everything we do, mouthwash, antibiotics, antacids, completely shuts down nitric oxide production. PPIs, these are proton pump inhibitors. People who have been on PPIs for 3 to 5 years, higher incidence of heart attack, stroke, and Alzheimer's. These drugs were never approved by the FDA for chronic use, only acute use for esophageal reflux disease. But yet you can go to your corner store, you can buy these drugs, you can take them every day. People have been taking them for 10, 15, 20 years. And it's not only increasing, this isn't increased risk, this is actual events. 20 to 30% increase in heart attack, stroke. Proton pump inhibitors accelerate endothelial senescence by reducing telomere length. They're shutting down nitric oxide production, inactivating the telomerase enzyme, causing shorter telomeres, increasing cardiovascular, renal, neurological morbidity and mortality. And then this paper came out a couple of months ago. People who have been on PPIs for 4 years had 33% greater risk of developing dementia. Again, these are important, indisputable clinical observations based on the peer-reviewed literature. It's our job to figure out mechanistically what's happening. PPIs decrease stomach acid production, inhibit nitric oxide production in the stomach. I've shown you that pathway. PPIs increase a molecule called asymmetric dimethyl L-arginine, which is an inhibitor of the endothelial nitric oxide synthase enzyme. So PPIs completely shut down endogenous NO production, creating systemic nitric oxide deficiency, decreased circulation, increased inflammation, oxidative stress, and immune dysfunction, insulin resistance, leading to dementia and Alzheimer's, plaque instability, plaque rupture, heart attack, stroke. So there is no miracle aspects about nitric oxide. We clearly understand the mechanism. The pathways are completely well elucidated. And then what about mouthwash? This study shows that if you take normal intensive patients, you give them mouthwash twice a day for 7 days, their blood pressure goes up. Their increase in blood pressure correlates with a decrease in nitric oxide production. This, again, a very important clinical observation. How do we explain it mechanistically? We started on this path about 20 years ago. The human genome only codes about 23,000 gene products. The microbiome, the bacteria that live in and on our body, outnumber human cells 10 to 1, and they express 3 million gene products, more than 10 times of what we see, or almost 100 times more than what the human genome codes. So the bacteria that live in and on our body are there to do things that we as humans can't do. This is a true symbiotic relationship. So our thought was, can we culture these bacteria? Can we characterize them and then see an association between these oral bacteria and blood pressure? And so this, again, this is the complete denitrification cycle. And again, humans do not have this pathway. This is only a bacterial pathway. So we did a study of people walking around the Texas Medical Center. We did tongue scrapings. We cultured the bacteria in their tongue scrapings. And here's the data we published 10 years ago. People who had the best microbiome, the more diverse microbiome, had the best blood pressure. Those that had the least diverse oral microbiome had the worst blood pressure, and there were none of these nitrate-reducing bacteria that we could culture. So this is what we call an association. It's not causation, it's association. Next, we went and we modified the IRB, and this was in collaboration with the dental school, where we only enrolled young, healthy dental students, oral hygienic students, and we gave them mouthwash twice a day for 7 days. We monitored their blood pressure. We did daily tongue scrapings. And then after 7 days, we stopped the mouthwash, allowed them to recover for 4 days. We brought them back to the clinic, and we measured their blood pressure, and we did tongue scrapings to measure their bacteria. We published this in 2019. 1 week of mouthwash use. This was a 21-year-old dental student, a vegetarian, and a triathlete. 7 days after mouthwash, we made him clinically hypertensive. His blood pressure went up 26 millimeters of mercury. We didn't change his diet. He was on no medication. All we did was destroy his oral microbiome with mouthwash. And then 4 days later, his blood pressure, fortunately for him, normalized. And we were able to detect the bacteria that disappeared when his blood pressure went up and the bacteria that reappeared when his blood pressure normalized. And we sequenced these bacteria, and you can see here they were expressing these nitric oxide producing genes. We could predict steady state blood pressure in these patients by the presence and number of these 4 different bacteria. Now this, let me spend a little bit, because this explains resistant hypertension. Resistant hypertension is a phenomenon that if you have high blood pressure, you go to your doctor, he puts you on different classes of antihypertensive medications. Typically, these are ACE inhibitors, ARBs, angiotensin receptor blockers, calcium channel antagonists, diuretics, or beta blocker, which aren't a frontline therapy for hypertension, but they're used. But yet 50% of the patients who are put on blood pressure medicine don't respond with better blood pressure. Why is that? Well, it's because it's not a renin-angiotensin problem, so ACE inhibitors, ARBs, aren't going to normalize it. It's not a disruption of calcium mobility, so calcium channel antagonists aren't going to do it. What we're finding is that the hypertension is a symptom of oral dysbiosis. So now, for the first time in the history of medicine, let's have a conversation with your patients and go, hey, are you using mouthwash? Oh, and by the way, do you use fluoride in your toothpaste? Because fluoride is an antiseptic, it's a neurotoxin, and it shuts down your thyroid function. But, and so 2 out of 3 people say, yes, I use mouthwash. 10 out of 10 people will say, yes, I use fluoride in my toothpaste. Okay, well, let's eliminate the mouthwash, get rid of fluoride, come back 30 days later, and their blood pressure is remarkably better. So no need for antihypertensive therapy. Let's give the body what it needs, remove from the body what it doesn't need. The body heals itself. So how do you improve nitric oxide production in your patients? And are there products that have been shown to increase this? So let me fast forward a little bit, because we developed product technology based on the discoveries we made in understanding endogenous nitric oxide production. So everything we do is called restorative physiology. And even our drug discovery program isn't employing pharmacology. We're not giving synthetic compounds that inhibit biochemical reactions. We're giving back a missing molecule, nitric oxide. So our whole thought process was, if your body can't produce nitric oxide, then we have to do it for you. Our products must produce this. So I developed an orally a solid dose form of nitric oxide gas, the only technology in the world that delivers nitric oxide gas in a solid dose form. But we also put technology in there that recouples the NOS enzyme. And because it's an orally disintegrating tablet that spends about 5 to 6 minutes in the oral cavity, it's killing the bad bacteria and enhancing the diversity of the oral microbiome. So this lozenge provides nitric oxide if your body can't make it, and it restores the body's ability to make it on its own. We also create a fermented beet powder. Beets have been the hero vegetable for the past 10, 15, 20 years. Beets contain a lot of oxalates causing kidney stones. Beets are the 3rd least liked vegetable in the world. and 95% of the beetroot products on the market don't do anything except turn your pee and your poop red and pink and cause a lot of anxiety and make people think they're having urinary bleeds or rectal bleeds. And then I made a topical nitric oxide for skincare and for wounds. So I'm not here to promote products, but I want to inform you about which products actually produce nitric oxide, and all these other products that are marketed towards nitric oxide don't produce nitric oxide. So my line of products, if your body can't make it, we do it for you, and we fix the reason your body can't make it. But here's a short list and picture of products that are advertised as nitric oxide, but provide no nitric oxide benefit at all. And how do we know this? Because we test it. We put it in our nitric oxide analyzer. We administer these products to patients, look at the increase in potential increase in nitric oxide production. And these products are placebos. In fact, we use these as placebos in our clinical trial because that's what they are. They're great placebos. And then there's a laundry list of these. So just these, I'm not saying these products don't contain good ingredients. They're just not nitric oxide products. Some of them should be labeled as multivitamins. They're providing amino acids, some antioxidants, but these are not nitric oxide products. They're trying to give your body the precursors or substrates to make nitric oxide, but the underlying problem is that you've lost the ability to convert these into nitric oxide. We're never deficient in these ingredients. We've lost the ability to convert it. So let me just make 3 points here. Beets do not equal nitrate. I've measured probably every beet product on the market. 95% of them contain no detectable nitrate or nitrite. Nitrate is not nitric oxide because we have to metabolize this by the oral bacteria. So if you're using mouthwash, it doesn't work. If you're on antibiotics, it doesn't work. If you're on PPIs, it doesn't work. And then arginine and citrulline products do not work in patients with endothelial dysfunction. So what to look for? Is there evidence the product works? Does it produce actual nitric oxide? Are there published clinical trials on the actual product? And has the inventor formulated or published original research on endobiochemistry? Do a PubMed search. There are a lot of companies out there who have these talking heads who've never spent a second in a research lab, wouldn't even know what a research lab looks like, but they're the talking heads for these products who have no idea about nitric oxide. So don't be fooled by creative marketing. Science and experience matter. Nitrate is like giving T4 to a patient with hypothyroidism. T4 or synthroid is inactive enzyme. It has to be converted into active T3 or T2. But again, this is dependent upon the thyroid enzyme, depends upon iodine availability. So again, nitrate is inactive. You must have the ability to produce it. So plant-based, potassium nitrate-based products only work in about a third of Americans due to simple lifestyle. Again, there's companies out there trying to sell you capsules, beet capsules. Well, let's just do the simple math. We need 300, 400 milligrams of nitrate to see changes. Beet powders, at best, are 9% nitrate. So that requires at least 3,500 to 6,000 milligrams of beet powder in a serving. And yet they're trying to convince you that you can get in a single capsule, which is 600 or 700 milligrams at best, enough beet powder to contain enough nitrate to manage blood pressure and generate nitric oxide. This is a game. So the math doesn't work. The science isn't there. You cannot deliver 3 to 6 grams of beetroot powder in a capsule or a gummy. Now there's companies out there putting grapeseed extract, resveratrol, acetylcholine, all these activators or stimulators in gummies, which basically is just a sugar matrix. Again, this requires a functional NOS. And if I wanted to take a seed and plant it in my garden, a corn, for example, or vegetable, and I soak that seed in kerosene and then put it in the soil, is it going to yield any fruit? Of course not. Same with grapeseed extract. You put grapeseed extract in a gummy, you glycate that ingredient, and you basically inactivate it. It's like it'd be just as good putting in kerosene and then taking it. And gummies, look, the last thing Americans need is more sugar. Sugar destroys the oral microbiome, leading to loss of nitric oxide production. Sugar glycates the NOS enzyme, causing it to become dysfunctional. So nitric oxide cannot be delivered in a gummy or a chew. In fact, it decreases nitric oxide production. So turn off your TV. Don't buy the gimmicks, the fraudulent, deceptive marketing used by a lot of these companies trying to convince you that you can get nitric oxide in gummies or chews. Again, what we do is completely different. We base product technology based on overcoming the deficiencies of endogenous systems. And let me take you through very quickly the clinical trials from product technology I've developed over the past 10 to 15 years, then we'll open it up for questions. This nitric oxide lozenge, you put it in your mouth, it produces nitric oxide. This is the same nitric oxide analyzer we use to test the traditional medicines. Generates nitric oxide. We can quantify it. We can detect it. It's vasoactive. You can see lowers blood pressure within 20 minutes, both systolic and diastolic pressures. 60 minutes later, further reduction in blood pressure long after that lozenge is gone. 4 hours later, we've recoupled the NOS enzyme, 15% improvement in endothelial function. If you take a picture of the carotid artery with an ultrasound, you get baseline pictures here, you give the lozenge. We've increased the diameter of the carotid by 13%. That's a 34% increase in blood flow. Now, if you take that SPECT scan I showed you at the very beginning, now you increase blood flow to the brain by 34%. You think that patient's going to get better? Of course. And this is showing plaque regression. This is using the lozenge twice a day for 6 months. We see 11% plaque regression. Not only can we, if we catch this early on, prevent the onset and progression of that disease, but we can actually see reversal. And then let me just end with this study here at Texas Children's Hospital. In pediatric disease, there's an inborn error metabolism. These kids are born without an enzyme called arginosuccinate lyase. And this is what we call the partial urea cycle that's present in every cell in the human body. And so as you can see here, this enzyme ASL converts arginosuccinate into arginine. But when these patients are born without this enzyme, they get a buildup of arginosuccinic acid. They excrete it in the urine. It's called arginosuccinic acid urea, or ASA is what we call it. So these kids develop hyperammonemia, and they'll develop liver dysfunction and cirrhosis. Many of these kids will have to get liver transplants at very early age, or they'll die of liver failure. But even though they're managed with diet and drug therapy for their hyperammonemia, they still develop systemic disease, blood clotting disorders, resistant hypertension, kidney disease, neurological dysfunction that's independent of their current hyperammonemia. So these physicians came to me in 2007 to try to understand this disease. And what we did, we modeled this in the lab. We created an ASL deficient mice, and we published this in Nature Medicine in 2011. And what we discovered was this ASL enzyme is what tethers the nitric oxide enzyme to the membrane. And so when these patients are born without ASL, this protein complex falls apart, and now they've lost the ability to produce nitric oxide. And when you look at this clinically through the nitric oxide lens, a nitric oxide deficiency explains all these symptoms and collateral symptoms that they present with, the blood clotting disorders. Nitric oxide prevents platelet aggregation. If you can't make nitric oxide, platelets become hyperactive. Nitric oxide is a major vasodilator. If you can't make nitric oxide, you develop hypertension. You start spilling protein and you get renal hypertension, spilling protein into the urine. So we thought, can we intervene in these patients? So this is a lifelong blood pressure profile of a single ASA patient. You can see here that for 10 years was very poorly managed, put on polypharmacy. And in February of 2010, he came to Texas Children's Hospital. His blood pressure was 210 over 115 in the intensive care unit. Nothing would lower his blood pressure. So we started giving him isosorbide, which 4 days later, these organic nitrates that produce nitric oxide. His blood pressure managed, released from the hospital. And he came back. And as I mentioned earlier, patients develop tolerance to these drugs. So he came back to Texas Children's a year later, taking 20 milligrams Isordil 4 times a day. Blood pressure was 185 over 110. We dosed him with our lozenge. 4 hours later, his blood pressure completely normalized. We got him off all prescription medication. His kidney disease resolved within 5 days. When we started him on the lozenge, his kidney disease resolved. His heart disease, when we saw him, he had a heart twice the size of a normal 15-year-old. 5 months later, normal cardiac function, normal cardiac size. We mobilized his own stem cells and completely remodeled his heart. So the nitric oxide that we delivered through this lozenge completely rescued a kid with an inborn error metabolism, a genetic disorder. That shows you the power of nitric oxide and giving this molecule. So obviously, these patients are given 20 to 30 grams of L-arginine per day because they can't make it. But yet again, arginine deficiency, even in these patients, isn't the problem. It's restoring the function of the enzyme, and it's giving an exogenous source of nitric oxide that otherwise they couldn't make. And to affect public kind of policy and public health, you don't even have to be that good at lowering blood pressure. A simple 5 millimeter reduction reduces the risk of stroke by 34% and ischemic heart disease by 21%. Now, let me take you very quickly through how, we focused on nitric oxide, but I don't want to take away from the broader kind of subject matter here and how you can integrate all this into really transforming patients' lives. This guy here is my dad. Dad turned 76 this year, but he's been rolling around in a wheelchair since 1984. He had an automobile accident, a T11 injury, so mid-back down, complete paraplegic. And so Dad used to evacuate through digital stimulation. Years and decades of doing this, developed a severe hemorrhoids. We had hemorrhoidectomy surgery. And his surgeon told him to go sit on a heating pad 30 minutes, 3 times a day to facilitate healing. And when you do this to a paraplegic diabetic, you cook him, unbeknownst to him, because he doesn't have any feeling. So obviously, this led to full thickness, third-degree burns on his backside, severe risk of infection. This is a clinically, severe condition here. And so we took him to Brooke Army Medical Center. The surgeons there said Dad probably wouldn't survive this injury because of his comorbidities and his age and paraplegia. And so I took this picture right after the skin graft. So they took a skin graft from his inner thigh. And so obviously, being paraplegic diabetic, there's poor blood flow here. So I created a nitric oxide topical to get blood flow to this graft so we could heal this wound. And we did an ostomy to divert the waste material into a bag to prevent the infection. So the surgeon said it would probably take if he survived this, by the way, it would take 9 to 10 months for it to completely heal. This was 2.5 months later. We completely healed this full thickness, third-degree burn simply by giving topical nitric oxide, improving the graft, improving the healing process. So this was a major win. But when we graft over the burn, he had developed a full thickness ischial ulcer. So this is under his right butt cheek here. I could put a tennis ball in this wound, osteomyelitis, osteonecrosis. Dad was septic, almost died. But when we got him out of the hospital, 10 days of IV antibiotics, again, we started employing these basic principles. Topical nitric oxide. I did ozone insufflation into this wound to try to kill the infection and to oxygenate the wound. But every wound care doc I took that to said we would never heal this wound. This is a non-healing wound. 4 years non-healing, we started to employ these strategies. This is today. We completely healed a 4-year-old non-healing wound simply by employing these strategies. What we do? Dad had severe dental infections, root canals, metal in his mouth. We took him and had restorative dentistry done, IV ozone insufflation, red light therapy, topical nitric oxide. We took his fat, spun down his fat, isolated the stem cells, injected the stem cells into the wound, around the wound, got about 90% growth, and then we closed it with a surgical flap. So this just goes to show you that if you employ these simple strategies, and again, nitric oxide is foundational, but it wasn't a silver bullet. We still had to employ these other strategies. Then, if topical nitric oxide can do that to a wound, what can this do to one of the largest organs, the skin? So I created a commercial nitric oxide delivery system, and I'll take you very quickly through the clinical trials here. This is using the topical nitric oxide twice a day for 30 days. You can see here the age spots disappear, the inflammation on the chin, inflammation here on the neck. This is a 52-year-old lady. Tone, texture, clarity of the skin improved. The broken blood vessels, a 50-year-old Hispanic male, varicosity. Tone, texture, and clarity improved. A wound here, a lady who had a facelift who started smoking and applying pressure here before the skin had a chance to fully reattach. Full thickness ulcer. The surgeon applied the serum 3 times a day. 10 days later, got complete closure. Polycystic acne, the topical nitric oxide kills the bacteria in the pustules, completely mitigates the inflammation, and complete resolution of polycystic acne in 30 days. This lady had a 15-year-old scar from teenage acne, and using the serum twice a day for 30 days, again, you can see almost complete remodeling, sloughing off the old cells, bringing on new cells, completely remodeling the skin. This is a smear of Pseudomonas, which is a bacterial infection found in most non-healing ulcers. The nitric oxide completely eradicates the infectious bacteria. Here's some of our clinical data from our topical drug. 4-year-old non-healing diabetic foot ulcer we heal in 30 days. 2nd-degree burn, 21 days, no scar formation, complete healing. And then Yale Medical Center contacted us. They had a 64-year-old paraplegic, 4-year-old non-healing wound. Started applying the topical nitric oxide. We completely healed this 4-year-old wound. in 195 days. And to date, we haven't seen a wound that we haven't been able to heal with nitric oxide. So let me just wrap up here, because what we try to do is recapitulate nature. And I think that's the intent of medicine. Medicine early on was applied physiology. Today it's applied pharmacology. We have to get back to physiology, restorative physiology. So this little guy here is Lincoln, who's now my 16-year-old. But when he was born, we were released from the hospital. The discharge nurse told us we should breastfeed, but if we can't breastfeed, give the baby the formula. So when we left the hospital, I kidnapped my wife and I brought her to my lab and I collected some of her breast milk. And then I compared it to the formula we were sent home with and just put it in my HPLC, and I quantified the nitrite and nitrate. So the breast milk, which was now colostrum, contained really high levels of inorganic nitrite, non-detectable in the formula. So then I went to the IRB in the labor and delivery unit of Memorial Hermann in the medical center, and we collected breast milk at different stages postpartum, and then we analyzed it. And what we found was colostrum was enriched in nitrite. As this milk transitioned into mature milk, nitrite went down, nitrate went up. And then we collected serially over 3 to 4 patients from the same donor over a period of time. And again, the colostrum was enriched in nitrite, and then once after 3 to 4 days, or about a week, it shut down nitrite expression in the breast milk and converted it to nitrate. And when you think about this, why is this? Well, babies are born sterile. They don't have an oral microbiome. They don't have a gut microbiome. So nature exquisitely concentrates nitrite in the breast milk, in the colostrum, because you don't need bacteria to utilize nitrite to make nitric oxide. But when you allow the colonization to occur, the breast milk then switches and provides nitrate to allow for the diversification of the microbiome, both in the mouth and in the gut, and then the body can make it on its own. And now we found out this is different in cesarean versus vaginal delivered babies. We can completely rescue necrotizing enterocolitis, still a 20% infant mortality, simply by giving nitrite in the formula. The other example came from people living in Tibet, 12,000 feet above sea level. If we go to Tibet, we develop mountain sickness, high altitude pulmonary edema, and people die all day, every day trying to ascend because they can't acclimate. So the question was, how do people who live at 12,000 feet above sea level operate? What is their adaptive response to low oxygen? And that's a very important question, because low oxygen can be environmental or it can be pathological, ischemic heart disease, COPD, emphysema. So we compared the people in Tibet to people that live in the US, primarily Houston and Cleveland, at the Cleveland Clinic. So even though these people that live in Tibet are breathing in less oxygen per inspiration because the partial pressure of oxygen is much lower at altitude, they deliver more oxygen per unit time. We collect the blood of these Tibetans, and they're producing about 50 to 100 times more nitric oxide than we do in the US. So the adaptation to breathing in low oxygen is an upregulation of their capacity to produce nitric oxide. And we published this in the Proceedings of the National Academy of Science in 2007. And now this explains altitude training. Olympic athletes go to Colorado or Mexico City or altitude to train because they upregulate their nitric oxide production, improve mitochondrial efficiency, improve mitochondrial biogenesis. So now when they come back down to sea level, they're a well-oiled machine. So it's not about altitude training inducing hematocrit and hematopoiesis. That's part of it. The adaptive effects to altitude training are through an upregulation and increase in nitric oxide production. So let me just wrap up here with kind of some take-home messages, because people ask me all the time, how do I improve nitric oxide? Well, you got to do 2 things. Stop doing the things that disrupt it and start doing the things that promote it. If you use mouthwash, you have to stop. Mouthwash kills the microbiome, causes an increase in blood pressure. You lose the protective benefits of exercise, and fluoride does the same thing. So buy a non-fluorinated toothpaste, buy a house filtration system, because fluoride's in most municipal water supplies. Get rid of mouthwash, get rid of fluoride. And stop using antacids. I mean, the data are very clear. These drugs are causing increased death from heart attack, stroke, and Alzheimer's. There's nothing good about antacids. Your body cannot and will not heal without stomach acid production. Stop eating sugar. Sugar's a toxin. Get rid of gummies. Don't get your nutrients in gummies. It causes glycation of the enzyme, develop endothelial dysfunction. Now, if you stop mouthwash, stop fluoride, stop eating sugar, now you've actually released the brakes on nitric oxide, and your body can actually produce it. Throw in some more green leafy vegetables, 20, 30 minutes of moderate physical exercise a day, infrared light therapy or just sunlight exposure 20, 30 minutes a day. And if you don't want to do that, then we have products that do it for you. And I show you this because this is a paper I published 20 years ago. And the point of this was that if we're making nitric oxide, we need to be able to control and dictate the metabolic fate of nitric oxide, because there's some reactive nitrogen species that you want to avoid. And if you don't know what you're doing and you push nitric oxide at an incompatible flux rate, then you can form these nitrosating agents. So these companies and these products out there who don't understand biochemistry and physical chemistry of nitric oxide can do more harm than good. Some of this is just naivety, but some of it, these companies are out there outright deceiving you and causing fraud because they know better, but yet they're putting profits before safety. So the greatest enemy of knowledge is not ignorance. It's the illusion of knowledge. Ignorance is curable, and I think that's why we're all here today, because ignorance is just a lack of information and knowledge. As we learn more through science and innovations and discoveries, ignorance becomes curable. Stupidity is something we can't deal with because it's the ignoring the knowledge and information and not applying that. And it's the greatest enemy of knowledge. So I just conclude that nitric oxide controls and regulates blood flow and oxygen delivery. The older we get, the less we make. That's responsible for cardiovascular risk and chronic disease. As I mentioned, diet and exercise are not always sufficient, especially if you're using mouthwash, fluoride, or antacids. Strategies for restoring overproduction will no doubt change the landscape of medicine and change the world. But we must use safe and effective nitric oxide product technology. Your body cannot and will not heal without it. And I think, I haven't made very many friends because these companies who are selling so-called nitric oxide products, I call them out. And to me, it's dangerous because it could kill an entire industry, because I hear people all the time saying, Nathan, you talk about nitric oxide, but I've been taking a nitric oxide product for 10 years and it doesn't do anything, doesn't make me better. So nitric oxide must not be that important. No, nitric oxide is extremely potent. It's extremely important. What you've been doing is being subject to deceptive marketing and fraudulent advertising. You're taking a product that doesn't produce nitric oxide. So there must be accountability in the science. These companies must be held accountable because it can kill an entire industry. In fact, an industry that will change the landscape of medicine. And again, I like this quote. These are quotes that have stood the test of time. What we've discovered are fundamental truths based on biochemistry and physiology. But these truths go through 3 stages. First, they're ridiculed. Secondly, they're violently opposed. And third, they're accepted as being self-evident. And certainly I've experienced all of these through my professional and adult career. I've been ridiculed by my academic colleagues. I'm being violently opposed now. I'm subject to a number of lawsuits from companies who don't like what we're doing, trying to shut down what we're doing because it's disruptive. If you're doing things that don't matter, people leave you alone. So I wear this as a badge of courage because what we're doing is disruptive and it will be violently opposed. But I'm patient enough to know the third stage is right around the corner. This will be accepted as being self-evident. So with that, I'll open it up for questions. For those of you interested in a book, my latest book, Functional Nitric Oxide Nutrition, I encourage you to follow me on Instagram. There's my YouTube page. And those of you interested in the product technology, the URL's up top. So with that, Michael, thank you very much for the opportunity, and I hope this has been informative.
Yes, it definitely has. And thank you so much for sharing all of that information. And thank you for sharing how people can get your book as well as follow you. So for anybody who'd like to ask Dr. Bryan any questions, you can raise your hand in Zoom. We'll put how to do so in the chat. We don't take questions directly from chat. So if you do want to ask a question, please raise your hand. So actually, the first question I was going to ask is, how is your work being received? And you spoke to that. Do you see anything that you're optimistic about with people responding to your work? Is it starting to absorb, is it starting to penetrate with some of the medical profession? Are people putting this into practice at all?
Yeah, my main objective today is, I travel, I give 30 to 40 lectures a year around the world, and really it's to educate and inform on nitric oxide. So one of my greatest joys and the gratifying things that I do as I wake up every morning, I have hundreds of emails, texts, or phone calls of people that we've changed their lives. And these are either from physicians who have given their patients the product or consumers who have bought directly and kind of, taken their health into their own hands. But to answer your question, yes, we are penetrating. People are starting to recognize how important nitric oxide is and finding our products that actually work. And we've got a number of clinics, hundreds, if not thousands, of physicians who now use this product technology in their daily practice, and it becomes part of their protocol. You know, if you're seeing these docs, then part of their protocol and being a patient in their practice is compliance. And so part of what they're doing is you start on the nitric oxide, kind of level the playing field, improve circulation, mitigate the inflammation. And now that allows the physician to dig a little bit deeper and get to root cause of what other ailments they may be experiencing. Because if you don't first correct the nitric oxide deficiency, a lot of their other symptoms will simply be masked by the nitric oxide deficiency.
So are you saying that people need to use these products? They won't be able to regain their nitric oxide production without them?
Well, you know, understanding how physiology and biochemistry works in a perfect world, in utopia, we can just give the body what it needs and remove from the body what it doesn't need, and the body heals itself, right? Medicines and doctors don't heal patients, cells heal patients. So we just got to mobilize and repair and replace dysfunctional cells. But the truth is, the food that we eat in America is depleted of most nutrients. And most of the food is sprayed with herbicides and pesticides. And then we're exposed to environmental toxicants like fluoride, like glyphosate, like 5G. All these environmental toxicants are interfering with normal biochemistry and physiology. So it's almost like we have to supplement to a certain degree and basically enhance the body's ability to overcome all these limitations that we're exposed to. But I tell people there's only two types of people who need nitric oxide. There's the people who are sick who want to get well, and there's the people who are well and don't want to get sick. So if you fall in one of those categories, then obviously you need nitric oxide. And I'm probably the best example of that because I've been doing this for 20, 25 years. I'm 50, but I have the biological age of a 32-year-old. And it's because I focus on my nitric oxide production, and I'm on an airplane every week. I'm in and out of hotels. I'm in different countries, exposed to different foods and cultures and pathogens. But yet I haven't been sick in more than 25 years. I haven't lost a day of work due to illness in 25 years. So I think that works. And I think medicine today is a reactive practice, right? People don't take action until they have a heart attack, stroke, or develop disease. We want to change that narrative and start to recognize symptoms that are signs and symptoms of nitric oxide deficiency. You know, all of us have this smartphone. And when the red light comes on in the corner saying we're about to lose charge, we panic. We drop what we're doing and we go charge our phone. I mean, we have red lights that come on all the time on the human body, and yet we ignore it. It's erectile dysfunction. It's an increase in blood pressure. It's metabolic disease. It's loss of memory. Those are red lights telling us, hey, something's going on. If you don't pay attention, you're going to die. And that's where, again, nitric oxide is not a silver bullet, but we have to first focus on that, lay the foundation, and then do all the other things that we need to restore cellular health.
Are you familiar with the work of Dr. Caldwell Esselstyn at all?
Yeah, look, I've had many conversations with him, and his data are indisputable in terms of reversing cardiovascular disease in patients and keeping patients from bypass surgery or even heart transplant by putting them on a plant-based diet. And obviously he's published on this, but the conversations we've had is he goes, Nathan, I see this and I don't have an explanation why some people employ this plant-based diet and see perfect reversal and regression of disease. Some people you put on a plant-based diet and they don't see any effect. They don't get better. And I go, well, are these patients using mouthwash? Are they using fluoride toothpaste? Because if they're killing the microbiome, they're never going to get activation of a plant-based diet into nitric oxide if they're using mouthwash or fluoride. And he goes, I mean, it was like the light went off. He goes, holy shit. I guess I've never asked my patients that. Like, well, now you can interrogate your patients. And as I mentioned before, 10 out of 10 people are going to say yes to fluoride, and 2 out of 3 people are going to say yes to mouthwash. That's just in the US. So get rid of fluoride, get rid of mouthwash. Now you can actually see the benefits of a plant-based diet because the body can actually convert it into nitrite and nitric oxide and lead to plaque regression.
And I know that in his books, he writes about reversing the damage to the endothelial lining, and he specifically discusses nitric oxide as being the benefit of healing the endothelial lining and getting things to flow. So now I noticed in the slide that you put up with the comparison of the diets, there wasn't a plant-based diet there. It was a vegetarian, which often has a high degree of animal products. Has extensive research been done and the comparison with whole food plant-based diets compared to these
Well,
other ones?
that was kind of the objective of that cross-sectional study with the vegetables, where we just took 5 vegetables across 5 different cities across the U.S. But it's difficult, if not impossible, to know if you're getting enough nitrate from your diet. And so the other problem is when you cook these, and the way we do the extractions in the lab is we actually boil these vegetables. So if you're boiling your asparagus or your spinach or your vegetables, you may be better off drinking the water in which you cook your vegetables in than eating the vegetable, because all water-soluble nutrients come out. Right. So what we're finding is that raw is best. It preserves what's there to begin with, but what may be there to begin with may be insufficient. And so raw is best, steaming or baking kind of preserves it, but cooking them in water is how we actually do the extraction to determine how much was there to begin with.
And you talk a lot about the microbiome. You talk about avoiding mouthwash. The other night during our panel, we were discussing Michael Greger's video on tongue scraping, and you informed me that actually he was talking about your work. Can you talk about tongue scraping and why tongue scraping has the impact that it does while brushing your tongue doesn't seem to?
Well, tongue scraping is an ancient practice that goes back to Ayurvedic medicine and some older cultures. And so I equate this to similar to tilling the soil or plowing the soil before you plant a seed. So tongue scraping actually gets into the crypts of the tongue. And so the bacteria that are responsible for producing nitric oxide are what's called facultative anaerobes. They're typically deep in the crypts of the tongue. So if they have oxygen available, they'll utilize oxygen to respire. If oxygen is not available because they're in this anaerobic biofilm, then they'll use nitrogen as a source, and that's kind of this flow of electrons of reducing nitrate to nitrite, nitric oxide. So what tongue scraping is doing is it's kind of plowing the soil and opening up these crypts, and now you're kind of destroying the biofilms and allowing that biofilm to recreate in a more healthy manner. So what we see in tongue scraping is you improve the diversity of the microbiome, and you're basically constantly tilling the soil, aerating it, and then allowing for this change in ecology. So tongue scraping itself is good, but in our 2019 paper where we referred to tongue scraping, in the patients that were tongue scraping and used mouthwash, those were the conditions where we saw the greatest increase in the blood pressure. So if you do tongue scraping, you open up the crypts and you use mouthwash, now that chemical antiseptic can penetrate deep in the crypts of the tongue, and you get better effective killing of the microbiome. And now that's when you see the great increase in blood pressure. So I encourage people to use tongue scraping, but never use tongue scraping and use an antiseptic.
And why doesn't brushing work the same way that tongue scraping does?
Well, the bacteria on the dorsal part of the tongue are near the gag reflex. So what we encourage people is tongue scraping, because you're applying mechanical pressure and actually getting back there, hopefully without gagging. And with toothbrush, whether it's, an electric toothbrush or whatever, the bristles aren't going to penetrate as far as the mechanical pressure from that tongue scraping. And two, some people get too far and they gag, and then they basically give up on, on brushing their tongue. And two, if you're using a fluorinated toothpaste, then obviously you don't want to brush the back of your tongue, because you don't want to introduce that fluoride into the crypts of the tongue to effectively kill the guys that would otherwise be, there would be a barrier to that fluoride to reaching those bacteria.
And when you do that, and I'll be honest with you, after our discussion last week, I went out and I bought a tongue scraper. When you're using it, how far back do you go? Is there any special technique, or you just kind of clear off the biofilm and you're good to go?
On the tongue scraping?
Yes.
Yeah, so what I do is I'll typically do 1 or 2 scrapes, and you'll see it. I mean, the kind of the stuff that comes off when you do that. But I'll do a tongue scraping and then kind of rinse it off and then go back and maybe try to get areas where I didn't get the first time. But yeah, 1 or 2 scrapes once a day is typically sufficient.
So you spoke about 2 Chinese herbs working synergistically with each other. I don't know if you named those herbs. What are those herbs?
Yeah, we didn't name it in the paper we published, but this was Dan Shin along with borneol. So the Dan Shin is an herb that's been used throughout traditional Chinese medicine. It's probably the mainstay of these herbs. But when you combine it with borneol, which is a crystalline salt, I think it's called Bing Ping in the traditional Chinese pharmacopoeia, but it's the work together that create energy.
Okay, great. And let's see here. I'm going to throw a couple of questions out to the audience. Jean D, please state where you're from and ask your question, Jean.
Yes, I have a question. Is there what is the latest scientific information about pulmonary fibrosis disease, the cause, and anything to reverse or cure?
Yeah, I mean, there's different causes for pulmonary fibrosis. I mean, we've studied this in animal models, and it's kind of the end stage disease of any pulmonary disease. It can be idiopathic pulmonary fibrosis, which means fibrosis occurs with no real reason. There's exposure to things like asbestos and mesothelioma that will lead to pulmonary fibrosis eventually. So again, it goes back to these basic principles that all human disease is caused by two things. Your body's missing something that it needs, or it's exposed to something that it doesn't. If you don't remove yourself from exposure to asbestos, then nothing's gonna make you better. So to answer your question in terms of kind of overt disease or diagnosis of pulmonary fibrosis, we've got in one of my first slides where I did the disclosures through Sage Pharma, we've got a class of drugs called G-SNO reductase inhibitors, and this is completely different than what I'm doing, but I'm on the board of this company. But it basically potentiates nitric oxide signaling. And in animal models, we see really good reversal of pulmonary fibrosis. So if you look up in the published literature, and these are animal studies, so preclinical, it seems that if we give nitric oxide, we can mobilize stem cells, we can remodel the lungs and reverse the pulmonary fibrosis. But again, if you don't understand what led to the onset and progression and the end disease that's consequence to them, then there's nothing that's going to be able to fix it. Maybe we can help to slow the progression, but until you move yourself from the source of exposure that caused disease and then replace missing nutrients to the body can actually mobilize stem cells and heal, nothing's really going to work.
Thank you. And you mentioned fluoride as being something to avoid in toothpaste, and a lot of the toothpaste that don't have fluoride have xylitol. Does xylitol have any negative impact on the oral microbiome?
Probably not surprising. There's two camps in dental medicine on xylitol. There's some who swear by it, who use it and want to use it. Then there's the camp that's the complete antithesis of that. They say you should avoid xylitol. It causes dysbiosis. So and that's just, I can't comment because we just don't have the answer. In terms of, there's plenty of data out there on xylitol, but we've never characterized xylitol on the effects of these nitrate-reducing bacteria. So what we do is, we just need to do the experiment and figure out exactly if it's affecting the oral microbiome. But to date, I don't have an answer.
Great, thank you. Next question is coming from Elaine W. Please state where you're from and ask your question. Oh, hold on one second here. Elaine.
Hi, sorry, this is Elaine from Iowa. I have a question on two different cancers. Multiple myeloma, which they often use stem cells as treatment. Could increasing nitric oxide benefit those patients in terms of stem cell harvest? And then the second question is around patients using Cialis, losartan, those types of drugs to open up the blood vessels in their tumors to increase the efficacy of chemo. Could nitric oxide benefit those patients as well? And final rapid fire questions. Is ADMA a good tracker for nitric oxide? Yes or no, as a biomarker? And have you tested Calroy products which use green seaweed? Thank you.
Yes, I'll take them one by one. Multiple myeloma or bloodborne cancers are typically always induced by some chemical toxicant, whether it's benzene or organic chemicals exposed to in your work environment. So what we're finding is that lymphoma, multiple myeloma, leukemia, you have to identify the chemical toxicant. And so until you remove that from the body, and you can do this through organic testing, you can do it through different labs in peripheral blood, then the multiple myeloma is never going to resolve. But obviously, if you can mobilize stem cells and replace those diseased or cancerous cells, which depend upon the ability to produce nitric oxide, then it can help. But again, until you remove the source of exposure, what caused the transformation of the blood cells, then there's never going to be a cure. And that's the frustration with oncology is the cancer docs never ask, why did you get this cancer? And how can you treat something that you don't know the cause? And that's why cancer patients, the field of oncology is still the wild, wild west. They treat cancers the same, surgery, chemo, and radiation, without any regard to the cause of the cancer. So I think if you can mobilize stem cells with nitric oxide, you can replace those transformed cells. But if you haven't eliminated from the body what caused the transformation in the first place, you're chasing your tail. The next question was on Viagra and losartan and all these to open up the blood supply of a tumor. So primary tumors are completely different than blood-borne tumors. Primary tumors, from my experience, are always caused from an infection, and 90% of it comes from a dental infection. And so cancer is very unique in the fact that it controls its own blood supply. So cancer cells can only operate and grow in a low oxygen, low pH, low voltage environment. And so we did this probably 15 years ago, where we were developing liposomal or nanoparticle delivery of nitric oxide gas with chemotherapeutic agents. So the strategy was, if we can get to the hypoxic tumor, the primary tumor, and then open up the microcirculation that's feeding that tumor, we can selectively deliver that chemotherapeutic agent to the rapidly dividing cancer cell. The preclinical data, was somewhat promising, but it's never been able to translate into human disease. But again, I think nitric oxide is critically important in metastatic disease. Number one, you have to figure out what caused the primary tumor. Did that patient have root canals? I'm finding that 90% of patients with primary tumors can be traced back to a root canal in several teeth. So you have to, again, address the root cause of what caused that cancer to grow. This goes back to Otto Warburg in the 1940s. It's the Warburg effect. It's aerobic fermentation, uncoupled mitochondria, and all the low pH, the acidic, low oxygen, low voltage environment. If we can overcome that, recouple the electron transport chain, superoxygenate that tissue, then by all accounts and by all metrics of cancer biology, the cancer cell can't grow and can't proliferate.
So,
and then the Calroy product, I'll answer the third question.
Sure.
Yeah, the Calroy product, look, there's good people in these companies, and I have a lot of respect for the people at Calroy, but just their strategy is different than what we do. So they got two products. One is the glycocalyx, where they use the seaweed to kind of restore the glycocalyx, which is the protective layer on the endothelial cells. The glycocalyx is extremely important in protecting the endothelial cells. But if you restore the glycocalyx, but you don't restore the function of the NOS enzyme, you still have an improved endothelial function. So they're two completely separate organisms, and they have to be addressed separately. So what I like is the Calroy glycocalyx product, because it does something that my products don't do, but yet my products do something that their products don't do. So I think it's a perfect combination of restoring the function of the glycocalyx, which protects the endothelium and creates this cell-free zone and protects from shear stress of damage to the endothelial cells.
So I guess it works in combination, kind of like the Don Shin and the Borneal.
Yeah, that's right.
There you go.
Absolutely.
So you mentioned root canals being something that you've seen cause issues. Is that because of the cavitations? We've had dentists speaking on cavitations and then bacteria that grows within them. Are those contributing factors?
Yeah, so the teeth are like the circuit breakers. We're electrical beings, and this goes back to the acupuncture meridians that date back thousands of years in Eastern medicine. So the teeth, all the electrical voltage and circuitry goes through the teeth, and so if your tooth has an infection, then it disrupts the flow of voltage. So just like if you trip a breaker in your house, the electricity goes off in that circuit. And so when you decrease the voltage through that circuit, then that organ that's tied to that tooth, and every organ in the body is tied to a specific tooth, then you shut down the voltage, you shut down the pH, you decrease the dissolved oxygen, you uncouple the mitochondria, and that sets the stage for cancer cell growth. So what is it about the infection? Number one, they're anaerobic bacteria that are utilizing and breaking down your bone, and then when they do that, they metabolize this, and so you release toxins in that. So now you become toxically burdened, and you're shutting down voltage. So what you have to do is you have to extract the diseased tooth, and then you have to go in there and actually kill the infection. And you can't do this with like irrigation or an aqueous antibiotic, because the tubules in the teeth and the bone are too small and the surface tension of water is too high. You can never penetrate into the bone to actually kill the infection. So what a lot of these dentists do, the really effective dentists, is use ozone gas, because ozone gets into the tubules of the jawbone of the tooth and completely kill the anaerobic bacteria. So yeah, there are a lot of things. And in fact, oral disease and asymptomatic root canals are really driving a lot of poorly managed chronic disease today, because nobody ever looks in the mouth. And most dentists will do today say, hey, the root canal is not a problem, but it's still dead tissue. If you leave any other dead tissue in the body, you're going to develop gangrene and sepsis, and you're going to die. Well, a root canal tooth is a dead tooth, and you may not die in a period of a week or 10 days. You'll just die 10, 15 years later from cancer.
And you mentioned getting rid of mercury. What happens if I know like there's special dentists that are SMART certified to remove mercury. Obviously, you're getting rid of mercury in the first place because it's so toxic. What happens if you don't have a person who's SMART certified and maybe they don't do a great job? How do you detox from mercury?
Well, number one, the dentist is exposed, and they're exposing their patient to the volatile nature of mercury if they're not removing this in a safe and effective manner. So mercury is a neurotoxin. Any heavy metal will scavenge nitric oxide. And in fact, if you've got a heavy metal burden, then typically you develop resistant hypertension, because even though we can replace nitric oxide or replete nitric oxide, the heavy metals will scavenge it and bind it before it has a chance to do its job. So mercury detox, I mean, there are a lot of protocols out there. Glutathione is critically important. You can do chelation therapy to bind these heavy metals. I use things like chlorella and spirulina, these algae products that can help bind metals and other toxins to clear it. So every morning I wake up and I take my chlorella and spirulina, and then I sit in an infrared sauna to help detox, mobilize toxins, and then you sweat it out, you urinate it out, you defecate it out, and you detoxify through deep breathing.
All right, we've got about 30 seconds or so. We'd like to leave the audience with any thoughts or any optimism on this message getting out to the wider world.
Yeah, we're moving our technology through drug trials. So we're in phase 3 clinical trials through the FDA. So not only do we develop consumer products in the nutrition, dietary supplement, and skin and beauty space, but we're undergoing the rigor and the time and the investment of getting this technology through the FDA, because I think the only way this will be accepted on a global scale in medicine is to prove that this technology is safe and it's efficacious for specific disease indications. And now, once we get these drugs approved and on the market, now the healthcare practitioners and physicians can actually write a prescription for a drug that's been proven safe and effective. And again, I don't want to intermingle this with drugs that are currently on the market, because most drugs are toxic. In fact, all drugs are toxic at some level because they're inhibiting a certain biochemical reaction. What we're doing is not pharmacology, it's restorative physiology. Understand the mechanism of disease to the extent that we can fix it. We know how to make nitric oxide. We know what goes wrong in people that can't make it, and we can correct that. So stay tuned. We expect to have these drugs approved on the market in the next 12, 18 months for ischemic heart disease, Alzheimer's, and our topical drug for diabetic ulcers. And that's just the beginning. Then we'll go after heart failure, pulmonary hypertension, and many other poorly managed diseases.
Great. Thank you so much for sharing all this great information. Really looking forward to seeing what comes out of your research or bringing this product to market. So thank you. And if we can unmute the audience so they can share their appreciation for Dr. Bryan, please.
Thank
you so much.
Any
Thank you.
medication or food allergies?
Thank you.
Thank you.
For